My name is Joan Eckerson, and I am a faculty member in the Department of Exercise Science and a longtime champion of the wellness program here at Creighton. And as part of the kickoff for year 2 of the Transforming Together wellness campaign, it is my great pleasure to introduce our speaker today, Dr. Stephen Blair. Dr. Blair is currently a professor in the Departments of Exercise Science and Epidemiology and Biostatistics at the Arnold School of Public Health at the University of South Carolina. Prior to that, he served as the Director of Research at the Cooper Institute in Dallas, Texas, and was responsible for the Aerobics Center longitudinal study, which was funded by the National Institute on Aging for over 20 years. Dr. Blair is a past president of the American College of Sports Medicine, National Coalition for Promoting Physical Activity, and the American Kinesiology Academy. He's received numerous awards from many professional organizations, including a Merit Award from the National Institutes of Health, the American College of Sports Medicine Honor Award, a Population Science Award from the American Heart Association, and is one of only a few individuals outside the U.S. Public Health Service to be awarded the Surgeon General's Medallion. He's internationally renowned for his research, which focuses upon the associations between lifestyle and health, with a specific emphasis on exercise, physical fitness, body composition, and chronic disease, and has published over 600 papers and chapters in the scientific literature. His most highly seminal work, which was on physical fitness and all-cause mortality, has been cited over 17,000 times. His topic today is physical inactivity, the biggest public health problem of the 21st century. Please help me give an enthusiastic welcome to Dr. Stephen Blair.
Well, thank you very much, Dr. Eckerson, and thank you all for coming out this afternoon. I'd like to say it's a pleasure to come here to Nebraska, but then I have to catch myself a little bit because I grew up in that really great state down there, Kansas. And I did live about 12 miles from the Nebraska border, halfway across the state. And there wasn't much I liked about you people, I'm sorry, except looking back, when I was in high school and college, Kansas had really strict laws on alcohol consumption. And the only thing they had was that 3.2 beer. So my God, let me get over to Superior, Nebraska and get something real. But no, it certainly is a pleasure to come here and talk to you today about my passions, and in the interest of transparency, here are my disclosures. I intend to address the 3 topics listed on this slide this afternoon over about the next, I think it's, 4 or 5 hours we have. And so if I spend maybe an hour and a half on each one, it'll be okay. It's no surprise to anyone in this room that non-communicable diseases are really the leading health challenge around the world. It causes a huge number of deaths, and you know what, well, it's listed here on the slide, and you can't all read, I take that. So I do have a pop quiz for you this morning, or this afternoon, and you have to vote on at least one of these. If you don't vote at all, you get an F. If you vote more than once, you get an F. And of course, if you vote for the wrong one, you get an F. So get ready, I mean, this is a challenge here. So which of these things causes more deaths around the world than any other item on the list? So how many say tobacco use? How many say obesity? You people are just sucking up to me. You're trying to be nice. You saw the title, okay. How many say high blood pressure? Yeah, a few. How many say physical inactivity? Oh my God, I've never had a response like that. High blood glucose, et cetera. Well, you can probably, I mean, I know it's a special audience for very bright and of course well-read and all of that. But typically when I ask this, the answer I get is obesity, obesity, obesity. The worst thing that ever happened to humankind. So occasionally I do a Google search, and here's one from a couple of days ago. Type in physical activity, oh, look at that. Yeah, more than 2 million hits, isn't that something? Eating too much. This is what we are bombarded with out there in the public literature, TV, radio, print, etc. Look at that, obesity, diet and obesity, inactivity and obesity. There are a few. Yeah. We put some comments like this in an article we submitted, call to action for physicians to pay more attention to physical activity, submitted to a medical journal. And some wise guy reviewer said, maybe it was a wise gal, I don't know, it might have been a gal, said, well, that's just Google. Well, that's nonsense, it's that stuff that's out there. What about PubMed? So we searched PubMed, and it was even worse in terms of the overemphasis on obesity and low emphasis on physical activity. Those of us in the exercise business, exercise science business, and there are certainly some of you here, I know, I hope you're familiar with this, but we were really pleased that last summer, the week before the Olympics, The Lancet, one of the world's leading medical journals, devoted an entire issue to physical activity. And for those of you, well, all of you, you need to be familiar with this, and certainly if you're in exercise science, you need to read it very carefully. One of the papers there, led by Dr. Ai-Min Lee, was to focus on what is the burden of physical inactivity around the world. So we dug up databases from I forget how many countries all over the world, spent a lot of time doing analyses. We were conservative at every step of the way. We didn't want to be accused of overestimating or overreacting. So here are the key findings in that report. You say, well, 6 to 10%, that sounds like quite a lot of non-communicable disease. 5.3 million deaths. But then, of course, you also know there are, 7 billion people in the world? What's 5.3 out of 7 billion? Sounds kind of trivial, doesn't it? But the bullet that she came up with that puts some of this in perspective, that's more than smoking. Even I was a little surprised by that. So, again, the title of the lecture, Physical Inactivity, the Biggest Public Health Problem. I do, in fact, believe that. Here's some summary evidence of that, but now I'll go to actually some additional evidence from this large study I've been working on for, 30 years or more. Many of you probably know about this, but these individuals receive a very thorough medical examination. It takes 3, 4, 5 hours to complete. Each doctor in this clinic sees 3 patients a day, to give you some idea of just how intense the breadth and the depth of the exam. And so it's not just questionnaire data, like a lot of data from epidemiology on activity and certainly on diet and so forth. Lots of lab data, body composition in the lab, not just height and weight, cardiorespiratory fitness, et cetera. And that's from a maximal exercise test on a treadmill. So here's the first paper we published on fitness and cardiorespiratory fitness and all-cause death rates. It's getting up toward 25 years now. But for both men and women, at that time we had 13,000 in the study. Get out of that low-fit group and it cuts your death rate in half or more than half. Huge difference. Get out here in the high fit, a little further reduction. So a question that should be occurring to you is, God, how do we get from here to there? What do I have to do? Is it do 2 hours of exercise a day? Well, no, actually. This is the bottom 20% of each age, gender category. And to get out of this, if you follow the U.S. physical activity guidelines, 150 minutes a week of moderate intensity, 75 minutes a week of vigorous intensity exercise, or a combination, mix and match, that gets you in the moderately fit category. And this is the next 40% of the distribution, and this is the top 40%. So this is not just a few marathon runners and triathletes. It's 40% of the distribution. To get here, you probably have to do the 300 minutes of moderate and the 150 minutes of vigorous or something of that sort. But just look at the benefit. Yeah, I challenge you, find me some drug that shows that difference in death rates as we see there. So, of course, when we published that first paper, a lot of critics said, well, yeah, but that fitness thing, that's genetically determined. If you got the genes to be a marathon runner and win the Olympics and so forth, it's all genetic. Well, can you name me something we can measure in human beings that is not genetic? Everything. I mean, there are some giants in the room that were not all normal height. And there are some guys in the room who have all that ugly stuff piled up on top of their head. And some of us are normal, right? Yeah. So again, anything you can measure in human beings has a genetic component. And Claude Bouchard, the guy who really invented the study of the genetics of activity, exercise and activity, has published a report showing that the genetic contribution to fitness is actually less than the genetic contribution to blood pressure, lipids, and body mass index. So sure, there's a genetic component. But to address this, we accumulated more data over time, and it's still quite a few years ago, almost 20. We looked at a group of 10,000 men who had 2 examinations now at this clinic. So we could classify them as fit or unfit at the first exam and the second exam, and then we followed them for, 8 or 10 years to see who lived and who died after that second test. They were all alive at the second test. It's really hard to do exercise testing on dead people, but I don't know, we're coming up toward Halloween, so who knows. In any event, those who were unfit at both exams, those who were unfit but improved, and then those who were always fit. So here are the death rates for cardiovascular disease mortality and for all-cause mortality. So these guys were unfit initially. They listened to the doctor, they took up exercise. When they came back, they'd improved, got out of the low fit category. And look at that, cut the risk, more than half, not quite half, for all-cause mortality. So, and we saw the same pattern in all age groups, 20 to 39, 40, 49, 50, 59, and 60 and older. So it's never too late to take up activity, improve your fitness, and reduce your risk. So in the early 90s, the American Heart Association labeled physical inactivity as the 4th risk factor, the 3 standard one that had been around for a while listed here. And so I began to, as we saw again and again, how important fitness was to preserve health and function. And well, how does it compare to these other risk factors? So here's a paper we published in JAMA in '96. Again, low, moderate, high fitness. These guys had none of these risk factors, any 1, any 2, or all 3. So there's a significant inverse gradient across fitness categories. Get out of the bottom fitness group, less likely to die. But look at this. These are the guys who smoke, had high blood pressure and high cholesterol. Their death rate there is about 23 per 10,000 man-years of observation. They're high fit with those other risk factors. Now look at this. The low-fit guys who did not have any of the other risk factors, the death rate is higher, 30 per 10,000. So in these data, this population, better off, smoke, have high blood pressure and high cholesterol, but get your 300 minutes of exercise a week and be high fit. What about some other health outcomes? I'll show you some more recent studies, go through some of these relatively quickly, but we see the same thing traditionally, again and again. This paper a few years ago, digestive system cancer deaths. So we're showing the data here in the die-away curves that epidemiologists like to use. These are the high fit or the moderately fit, and these are the unfit. They die away at a faster rate. Now this epidemiology is a gruesome business. And when you're doing this kind of work, you have to count dead bodies. And what's coming up next week? Halloween. I know some of you have picked out your costume already. Some of you haven't. So let me give you a suggestion. Epidemiologist. Bernie Franklin. I'm going to our Halloween party as an epidemiologist. Fitness and breast cancer mortality, same sort of pattern. And I'm not belaboring these points, but all of these data are statistically adjusted for many other risk factors. And again, most of these measured carefully in the lab. So we can't make this association go away when we look at potential confounding variables. Incident hypertension in women. And note that there are men and women in the study. I've sometimes showed slides with both. Sometimes I'll show just men or just women, no bias. But the results are essentially the same whenever we have enough data to do parallel analyses in the 2 sexes, and we see pretty much the same results. So developing hypertension across fitness categories. What about people in the prime of life? Oh, well, no, wait a minute, sorry. I'm getting May to redo this study because, so we published it a few years ago, and my definition then was 60 and older, and now it is 70 and older, so she's going to have to redo this report. But men and women together in these analyses, low, moderate, high, et cetera, et cetera. But now by age groups, same pattern in each age group, and even I will call these people old, 80 and older, and look at the death rate in those who were high fit, who were 80 and older. That's 13 or something like that per 1,000 person years, compared to 27 or 28 in the low fit people who were at least 2 decades younger. You getting the idea? Fitness is important. And how do you get to be fit? Do that regular physical activity. Now, those of us in the prime of life have come to accept that we will all die. The death rate actually is 1. And I know some of you, what, I'm going to die? I hear these students. Yeah, you're going to die. But there are things that some of us, as we get a little older and wiser, fear more than death. And this is one of them, dementia. So we published this paper, just last year, I guess. If you want to avoid having the doctor write dementia as one of the causes on your death certificate, then get out of that low-fit group. It's much less likely to write dementia on your death certificate. And there's a lot of research now bubbling up just over the last 5 to 8 years showing that exercise is good, not only for the muscles, not only for the heart, good for the brain. And that's true for old people, it's true for young people. Exercise, you're getting the idea, it's kind of good for everything, isn't it? So again, the Halloween theme here, I guess. Here's the Grim Reaper. He's an epidemiologist, by the way. So how fast can he walk if you want to avoid him? Well, here's an interesting paper published a couple of years ago in the British Medical Journal. Some older men, they followed them up for about 5 years. They measured their walking speed just over 6 meters. Time them, how long did it take, 2 tries, et cetera. What's your speed, how many meters per second can you walk? So how fast does the Grim Reaper walk? Well, those who could walk more than 0.82 meters a second, and that's about 2 miles an hour, they were 23% less likely to die. Good, just going faster than 2 miles an hour. Death's preferred walking speed is less than that, less than 2 miles an hour. And death's maximum walking speed, I guess it's 3 miles an hour. None of the guys who could walk 3 miles an hour died. So I timed myself on the treadmill this morning and walking along at 3.2 mile an hour. I wasn't anywhere near maximum, but so I'm still ahead of this guy, I hope. Collapse, sudden cardiac death. Okay, let's look quickly at fitness and health outcomes in various groups like those with chronic disease. So remember, in this clinic, very thorough exam. The average age of people when they come there is about 45, so many of them who come already have a chronic disease. Like there were 8,100 men who already had physician-diagnosed hypertension. And of course, at their examination, we measured their blood pressure. And some of them, their blood pressure was normal, under control. Some of them still in stage 1. And oh my God, some of them were in stage 2 hypertension. Well, low, moderate, high fit, you're getting kind of sick of seeing this pattern. I have been accused by those that don't like me, and there are a few of those out there. Say Blair doesn't do any new research, he just makes new slides. Look at it, same pattern. But look at this. The guys whose they're hypertensive, their blood pressure not well controlled at all, their cardiovascular disease incidence rate is 10 per 1,000 man years. What's a man year? What's 1,000 man years, you might ask? I know this is epidemiology jargon. It's one guy living 1,000 years or 1,000 guys living 1 year. 1,000 man years, get it? Okay. I don't know, it sounds a little crazy. But look at the cardiovascular disease incidence in the guys whose blood pressure was controlled. but we're low fit. It's 17 per 1,000 man years. So you doctors, nurses out there who work with hypertensive patients, don't congratulate yourself too much when you help them get their blood pressure under control. You prescribe a medication, they take it, good for you, good for them, blood pressure under control. But then you ought to be thinking, which one of these groups is she in? Because there's a huge difference in whether she's going to have a stroke, heart attack, etc. And then finally, not finally, I mean, I've still got hours to go here, but I've been talking about cardiorespiratory fitness, and very recently, and in the most recent U.S. physical activity guidelines, there also is a recommendation for resistance training. 2 days a week, major muscle groups, et cetera, et cetera. And it's because it's fairly recently have we obtained data on muscular strength and health outcomes like mortality. Now, we've known strength is important for athletic performance in some jobs and so forth, but it's pretty recent that we've learned about strength and health. So here in this population, we have a subset where we measured muscular strength in the lab. So this is 1 repetition maximum bench press, 1 repetition maximum leg press, and then we cobbled those data together and came up with thirds of muscular strength. Get out of the bottom third, cut your risk of dying substantially. No real difference here between these two for some reason. Trend across cardiovascular disease. So muscle strength is also important. And these data are adjusted, I think maybe the next slide shows that, adjusted also for cardiorespiratory fitness. So this is strength, fatness, and cancer mortality. Very familiar trend to you, adjusted for a variety of things, including cardiorespiratory fitness. So both kinds of fitness are important. They do overlap a little bit in terms of health outcomes, but both are important. So do that resistance training. And then, of course, people say, well, yeah, but that's just epidemiology. We need experiments. We need randomized trial evidence. And I don't have time to show you a huge amount of that. But one of my favorite ones recently is from a study we did, a large study we did in postmenopausal women, overweight or obese, mildly hypertensive, 464 of them, tightly controlled laboratory study, control group, and 3 different exercise groups. And the quality of life paper that we published a couple of years ago, all the quality of life scales, most of them showed just a pretty good linear trend, but the one I really like is change in energy, and that's do you feel energetic or not? So note that this group of women only did 72 minutes of moderate intensity activity a week. These did a little more, close to the recommendation, and these 1.5 times the recommendation. But just doing 10 minutes a day, you feel more energetic. You feel better. I think it's worth doing. Don't sit so darn much. I will expect a standing ovation. And you can even stand and jump up and down a little bit if you really want to. A study a colleague of mine did when we were working together in Dallas, young adults with mild to moderate depressive disorder, diagnosed in a depression clinic at the UT Southwestern Medical School, not just from some questionnaire. They were randomly assigned then to placebo control, where they came to the center and did a little light stretching, or 80 minutes a week, walking on a treadmill, or 180 minutes. And Andrea tried to take out the social interaction. And if you have depressed patients and you have them come to aerobics class and Zumba class, well, they may feel better just because it's fun. So to take that out, she had them walk on a treadmill in a closet. So, but look at this, those getting just a little more than the guidelines, 40% of them had remission of their depression symptoms at the end of the study. And this is spot on what the meta-analyses show for drug therapy and cognitive therapy for depression. So I'm not saying we shouldn't have drug therapy for anything. Sort of drug therapy for depression. I'm not saying we shouldn't have that. It's just that exercise is a medicine. It's another medicine. And I need to make a slide of this paper we also did with Dr. Trivedi, where we took people from his center where he failed to get remission of their symptoms after a traditional psychiatric approach. Then we randomly assigned them to exercise. Exercise got a lot of them better. So it's a medicine. So which is more important? Now let's get to the fitness, fatness issue. There's enormous confusion about this. I already alluded to it earlier with that Google slide. And energy balance, I know you physiologists, it's much more complicated than this. Lots of complex mechanisms, appetite regulation and so on. But the laws of thermodynamics are valid. And if you consume more than you burn, that energy gets stored where? As fat. If you burn more, then you have to find that energy, so you burn up some of the fat you have. So this is the really simplistic model. But there's huge confusion about obesity in public health. As I've already alluded to, it's all over the popular media. Don't get me started, I'll have my heart attack. You will hear someday, Mindy will report, my niece here, that Uncle Steve died. They found him dead at his desk because he found another stupid paper on obesity and health outcome X, and they didn't even mention physical activity. Junk science, pay no attention to those. So do we pay too much attention? I think we pay more attention than we should. I'm not saying ignore diet. Obesity is an international epidemic, no question. I'm not saying ignore it, but we just need to pay more attention to physical activity. Now here's another Google search from over a year ago. Type sugar is bad, tobacco is... Look at this. Sugar is worse for you than tobacco. And I didn't put the slides in. It's also worse for you than cocaine, worse for you than heroin, and worse for you than anything else you can think of. I imagine sugar's going to get more hits because you were bombarded constantly by sugar is poison, sugar is toxic, sugar causes all the world's evils, and et cetera, et cetera. And obesity, oh my God, obesity, causing all the world's problems, by the way, including terrorism. Think of the pictures of the terrorists. Timothy McVeigh, some of you remember him, Oklahoma City bomber, Osama bin Laden. Think of these terrorists, tall, skinny guys with hair. Watch out for them. And they're out to get us because they hate fat people. Well, here's a slide again. You notice that on my disclosure, I am transparent. I get a lot of research funding from the Coca-Cola company. So if you think I'm totally biased, they don't control the research. They give the university the money, we do the studies, and et cetera. So Coke doesn't, these are not Coke's data, but in the interest of transparency. But here in Australia, over this period of time, obesity rates tripled in Australia. Sugar intake went down over that period. Now look at this. Let's see, do you have McDonald's here in Omaha? Are there any? Is it possible to find McDonald's? So here's a meal for a family of 4. Can you imagine, well, what's her name, Trish? Trish, is she here? Okay, get ready to faint, Trish. Yes, okay. Had lunch with Trish. And she can't imagine anything any worse than this. Big Macs, cheeseburgers, chicken wings, fries, Coke, et cetera, or, well, I'm not sure. Trish, you don't even like chicken, do you? But anyway, home-cooked meal. Only cost half as much. Note that difference. But you could have some roast chicken, some whole wheat bread, salad, baked potato, and that's a healthy meal. So again, everybody can pass this. Which one of these meals has the most calories per person? Who says McDonald's? Some of you are suspicious of me, I know. And how many say the home-cooked meal? Not much traction on that one. Well, yeah, look at the McDonald's. 900 calories per serving and 37 grams of fat. Oh my God. It's a wonder we have any people left. And of course, they could have had this home-cooked meal, which, 34 more calories, 2 more grams of fat. Oh, it surprised me when I saw this. Again, we are bombarded with a lot of false information. Eat a healthy diet. I believe. Did you see what I ate? No, Trish left before lunch. Lots of broccoli, that asparagus you pointed out. No chicken, etc. I believe in healthy eating, but just don't believe all the stuff you hear about how bad fast foods, sugary drinks, etc., etc. Don't believe it. Say, show me the data. Show me the data. Okay, fitness and health outcomes in various population subgroups. For example, here in these 2,300 men with physician-diagnosed type 2 diabetes. So they're all sick. They've all got a serious chronic disease. So you cannot escape the doctor's office without having your height and weight measured. I try every time. Get on the scale, fat guy. We're going to see how much. And they will these days calculate your body mass index. And I assume you're all familiar with that. Normal weight, overweight, and obese. Well, these guys also had the fitness test. Low, moderate, high fitness, low, moderate, high fitness. Now, there aren't a lot of obese guys who are high fit. You could find one here, I think, if you looked around. But so in this, we combine the moderate and high fit. And you know where I'm going with this. This is the cardiovascular disease mortality risk. Look at this group, the obese guys with diabetes who are at least moderately fit. Their risk of dying is this, this is the odds ratio. Here's the reference category. They are, the fat guys with diabetes who are high fit are a little higher risk than the normal weight guys who are high fit, but they're a much lower weight than these guys who are normal weight with diabetes, but unfit. They're 3 times more likely to die in the next, I think this was, 12 years of follow-up or something like that. And I'm not saying ignore obesity. Certainly do not ignore visceral adiposity in clinical settings. Yes, those things are, but much of the risk associated with that is eliminated if you are active and fit. Another paper published a few years ago on men and women 60 and older. And again, this is percent body fat measured in the lab. Not just weight, not just BMI, percent fat. So these are the normal fat ones, and these are the over fat ones. And the definition we used was 25% or more for men, 35% or more for women. There's no difference in death rate between the normal fat and the over fat in the ones who are fit. There's no real difference in the death rate in the normal fat and the over fat in the unfit. Where is the difference? It's between fit and unfit. And we've been, again, bombarded, as I keep saying, not only about sugar and all McDonald's, but 2/3 of Americans are overweight or obese. You've heard that. You've all seen that in the newspaper, medical journals, what have you. Well, if we actually lowered the cut point, now you young people won't remember this, but in 1998, we lowered the cut point, the bottom cut point for overweight from a BMI of about 98, I think it was, something like that. No, in 1998, we lowered it from 27 point something to 25. And so we made 50 million Americans overweight overnight by changing the cut point. So if we would now lower it to 23, which some very prominent professors are arguing for, then we could maybe say 80% of Americans are overweight or obese. Make it the bigger problem. Well, actually, what some of that crowd overlooks is overweight really isn't bad for you. And here are these large National Health and Nutrition Examination Survey data from Catherine Flegel. The reference category is normal weight. If you are really skinny and underweight, there are 33,000 more deaths per year in the United States in these tiny people. Now, that's probably largely due, many of them have serious chronic disease. If we look at the overweight individuals, and again, this is comparing to the normal weight, there are actually 86,000 fewer deaths in the overweight. If we go to class 1 obese, well, there's 30,000 more deaths, but it's not statistically significant. Class 2 obese, okay, about the same as this. Catherine recently published a big meta-analysis, nearly 3 million people, pretty much the same results as it. Overweight is not a health hazard. Well, no, wait a minute, it can be a hazard, I mean, if you're trying to get a date for the prom, could be a problem for you. If you're trying to get a job, if you're trying to get promoted, etc. But in terms of health, overweight, not a problem. Class 1 obesity, especially if you're active and fit. So does it matter if you are overweight or obese in middle age? And does it matter if you listen to the doctor and nurse and lose some weight? Well, here's a paper we published a couple of years ago. These men, 14,000 of them, all had 2 of these examinations. Some of them had as many as 25. The average number of exams was about 4.5. So we could model changes in weight, fat, and fitness to the last exam, and then see who lived and who died after the last exam. We had over 900 deaths during almost 12 years of follow-up. And here are the results. This is body weight, percent body fat, and these are fifths of change, so 20% in each group of change in those variables. These guys, I think there were 46 on average at baseline. The ones who gained weight, lost weight, stayed, it didn't matter. It didn't matter. Fitness, on the other hand, you improve your fitness, you reduce the risk of dying. So doctor, stop hassling your fat people so much about weight and be sure they're being physically active, improving their fitness. Don't get your hopes up. This is a summary of the first tenth of the talk. And epidemiologists like to calculate a thing called attributable fraction. And it's a calculation that gives us an estimate of the number of deaths or the percentage of deaths in a population that we can say is caused by a particular characteristic. And the calculations are based on, well, how strongly is this characteristic associated with mortality, in this case mortality, and then how prevalent is the condition in the population. Now, if Rolls-Royce automobiles were death traps, I don't give a darn. I've never been in one. I worry about my friend Joan and her fancy car, but yeah, who cares? Because there's so few of them. Now, if Toyota Corollas were death traps, ooh, potential for a lot of deaths in the population. So you get the idea for the calculation. So here from 50,000 of these people that we've been following, these different exposures, all of these data are statistically adjusted for age, year of examination, length of follow-up, and each of the other items on this figure. So low fitness in this population, we calculate, caused 16 to 17% of the deaths. Obesity, 2 to 3%, and so forth. You can all read. My colleague Kareem Khan at University of British Columbia came up with a word I like. He said, well, these data show that low fitness is more harmful than smoke-a-diabesity. If you add up these percentages, obese, smoking, and diabetes, yeah, you still don't get to here. This is how big a public health problem it is. Hence the title of my lecture, The Biggest Public Health Problem of the 21st Century, and we may be getting worse as we continue to engineer movement and energy expenditure out of modern life. So, okay, you wouldn't have come if you weren't convinced that it's a good idea to be active. How do we get people to be active? Again, those of you in the business know that in 2007 we released the first official U.S. government physical activity guidelines, and what we stated there has I won't say been adopted because it's the same databases that people around the world have looked at, but in 2010 the World Health Organization released their recommendations, and they're essentially the same, 150 minutes moderate, so on and so on. Canada's done the same, Australia, Finland, England, on and on around the world. So this is what people should do. But as I showed in the one slide, that's a good target, 150 minutes a week. But if you can only get 149, is that still some benefit? Remember the one slide on energy in those postmenopausal women? 72 minutes a week, so which has led to them in our guidelines, we'll try to avoid inactivity. Some activity is better than none. More is better than less, at least up to some point. And don't forget the muscle strengthening activities. So how do we do this? How do we get people to be more physically active? I've done quite a bit of research with, well, I don't do any of the actual work, but I've got really brilliant people I work with, some of the world's leading behavioral scientists on how to implement physical activity programs. And we have to bring behavioral science into medicine, public health, healthcare, to help people manage their behaviors. Again, I'm focused on activity, but whether that's wearing condoms or not drinking and driving or fastening your seatbelt or eating your whatever. It's behavioral strategies and approaches that we have to promote more and help people learn how to use. Balancing your checkbook, flossing your teeth, et cetera, et cetera. So here are some of the main theoretical models for social science. I'm not a psychologist, so if there's a psychologist in the room and wants to argue that one of these is better than the other, wait till the next speaker comes. I think they all have merit. There are all items in these models that are useful as we try to work out ways to help people practice healthy behaviors. And these are some of the models. I know some of you, and I've talked with you earlier today, pedometers, accelerometers, step counters, Fitbits, whatever. That's self-monitoring. If you want to change a behavior, it kind of helps to know where you are with that behavior. Yeah. How many, your dentist wants you to floss every day. Well, how many days a week do you floss? I do it every day. Okay, well, good for you. Well, I'm not sure. Well, let's track it for a while and see. What are you doing? And then set a goal. Okay, I'm only flossing twice a week. Next week, I'm going to try to do 3 times. And I did that, so the week, maybe I can get it up to 4. Finding social support to help you make these changes and maintain the changes in eating, physical activity, what have you. This is a really powerful one, and a crazy example I've already thrown out here to a couple of you today. If social media, social support, and iPhones, et cetera, can get people on the streets of Tripoli to get shot at, get them on the streets of Omaha to take a walk. You think we might be able to do that through social media, social support, social contacts, et cetera? Don't have time to go into these things in depth, but the model that Professor Bess Marcus, who's the senior behaviorist I've worked with, brought into the physical activity arena, and the one that I like, is the stages of motivational readiness. So for any behavior, you're somewhere on this spectrum. Now, pre-contemplation means, well, I've never even thought about quitting smoking. Well, could you think about it, et cetera? And then you can move, and we say moving someone from pre-contemplation for one behavior to contemplation is an intervention success. They haven't done anything yet, but they're at least thinking about it. Or then preparation. Well, they haven't started walking yet, but they did buy a pair of walking shoes. That's a start. And then you try to get them into action, meeting the guidelines, what have you. And if they do that for 6 months, then they're in maintenance. Try to keep them in maintenance. So I do like this model. And Professor Marcus has a book in which he describes very short scales to measure the individual strategies and so forth. So this is what people would like to do, and wouldn't this be wonderful? If we say, okay, smoking is bad for you, and the next day everybody quits. But it's typically doesn't work that way. It doesn't necessarily work through the model like this either, because you might, then you fall back. Wait a minute, I heard this not on Fox News who said that exercise was bad for you. So maybe I'm back to pre-contemplation. Or you can go cross up and down, back and forth. And this is the way we are. These are the kind of critters we are. We go from maintenance even to action, or maybe from maintenance, I guess the last one, back to preparation. But working through these stages and trying to get to maintenance on whatever health behavior of interest you're concerned with is a reasonable way to go. And this does work. We've shown it works in physical activity intervention. So probably no one in this room is in pre-contemplation. I have had people enroll in big randomized trials who, according to the scale, were in pre-contemplation. I remember the first big study, 235 randomized, and I think there were 2 who were in pre-contemplation. And my God, it was very extensive testing, a run-in period, 2 or 3 weeks, a lot of lab tests and so forth. And why did they go through all that? They were in pre-contemplation for exercise. And then later, one of the staff asked them, and these were both guys. And what do you suppose the answer was as to why they were there? My wife made me come. Yes, you got it. So, okay, women, you can be really good at moving from pre-contemplation to contemplation. So the pre-contemplation, again, is not intending to change. I don't think smoking is harmful. Well, I'd kind of like to, but I don't have time. The cons outweigh the pros. Well, I don't think I could do it. I tried once before, so forth. Now, then the contemplation stage, well, I intend to change. I know it's kind of bad to not exercise. It's, this smoking is going to cause lung cancer. I'm not too sure what I should do. How do I get started? I do kind of see the pros and cons are, the cons outweigh the pros a little bit. So, okay, I want to try to do something. What do I do next? And so on. I need to have some self-confidence that I can do it. So again, I don't have time to walk through all those stages, but if you are interested and you work in this area, Professor Marcus has a book from Human Kinetics, Motivating People to be Active, and it really is the Bible. It's in its a second edition. So we hear a lot, again, in the press and on the internet, oh, this is the best exercise, my secret exercise. Look at me now. I mean, you go to the drugstore and you see all these magazines, and 80% of them are young, beautiful, partly clothed women, and there's always some secret exercise tip that made me look like this, or secret diet tip that made me look like this. So what's the best exercise? I heard about this, my friend. Well, it's the one you will do. No matter what's the best for me or Joan or anyone else, the best exercise for you is the one you'll do. And find that, get on it, and keep after it. So are you too busy to be fit? I mean, God, everybody here is busy. I don't know how you manage to find time to come and listen to this old guy babble on, but, oh, wait a minute. President Reagan was active. President Bush the first, Clinton, Carter, runners. W was really, not my favorite president, I have to say, but I knew W, and can I say this here? He's the only president I've seen naked. What? Well, it's because we worked out in the same fitness center in Dallas. He's seen me naked too, for that matter. But they've been active. President Obama, active. And wait a minute, you're too busy, and President Obama finds time to be physically active? President Bush did, both Bushes. You're really too busy. And there is a new advocate for physical activity. Francis. According to an editorial just a couple of weeks ago, and I did confirm last night, he's a Jesuit. This is Jesuit. So it should, and I'm not a Catholic, but I have to say that from his first appointment, everything I've read, I really admire. I mean, he's a good guy. That's my impression, that he's really a good guy. And he doesn't live in the Pope Palace, whatever they call it. He lives in a Spartan guest house in Vatican City. And the other day, he met a bishop who was standing outside waiting for a car. Can't you walk? Pope Francis. Let's get him here. Let him know what you're doing. He'll be impressed. Advocate for physical activity. Good. And then I do notice, maybe he's been here, because I noticed this. Some of these buildings, please excuse my stupidity using my iPhone camera and not knowing how to turn that off, but have you had, and in this very building, stairs, find the stairs. Yes, we actually did research some 20 or 25 years ago in a high-rise building in Dallas, and we got a lot more employees taking a lot more stairs, just putting up signs at the elevator. Waiting for the elevator, taking the stairs takes this amount of time, taking the stairs so many calories and so forth. And we got a big increase in stair climbing. So I like these signs. Keep them up. More of them everywhere. There's no there's no elevator down here, so I'm going to have to walk upstairs. So anyway, inactivity, I do believe, is the biggest public health problem in the world. We need serious interventions and serious policy efforts to change it. I have to tell you, and I'm not saying this just to suck up to you and be nice, so you'll take me to a nice place for dinner tonight. I am really impressed with what I've learned about what's going on here at Creighton across many different groups, and from the provost office on down, and pharmacy and nursing and physical therapy and exercise science and medicine. Who am I leaving out? I mean, coming together to really address healthful living. So you folks, trust me, I travel around the world a lot. I go to a lot of universities. You guys have a chance to really be up there at the peak of this, so keep up the good work. And the final solution, this miracle drug. I got this up in Canada, giving a talk like this in Abbotsford. It's from Dr. Exercise's Medicine, and it is kind of a big pill, but you know, with a couple of pints like some of us had last night over here at Blot, you could get it down, or you could put it on your belt. Track your physical activity, set goals to improve your activity, get up to that 8 to 10,000 steps a day, the 150 minutes of walking a week, and your life's going to be a whole lot better. You're going to live longer, you're going to be healthier, you're going to have more energy, and students, you're going to get better grades if you do that. Thank you.